Thanks for coming, everyone. So, as Yan said, I'm here to talk about a project that we carried out at the CGP over the past few years under Professor Jolie, the central aim of which was to better understand and help improve health communication practices with intersex adults in Canada. In that spirit, the first part of the title has a double meaning: communication as care. It highlights first that health communication is a component of healthcare alongside medical interventions. And I mention this because people don't always think about the impacts of health communication, but how and what we communicate also affects patient outcomes and well-being for better and worse. The second meaning is the idea of enacting care for this population through how we communicate. So approaching communications with intersex people in informed, sensitive, and respectful ways that affirm bodily diversity, challenge stigma, and honor autonomy. In other words, communication is caring. So in an ideal world, communication as part of healthcare and enacting care through communication would be one and the same. But as I'm about to discuss today, they're not, and that is the issue this research strove to address. When presenting on this topic, I also want to acknowledge that I'm not intersex myself. So what I share today is grounded in research, conversation, and collaboration with intersex scholars and advocates, including the reminder that the burden of education and knowledge sharing shouldn't always fall on intersex people themselves. And that it's important to follow community-led guidance regarding best practices and research with this population. This research aligns with the Center of Genomics and Policy's work more broadly in that intersex variations are often genetically based, and intersex people are a minoritized population who face significant health disparities, discrimination, and human rights challenges in healthcare. I have a bit of a cold, so thank you for your patience. I might have to cough a bit. My voice is a bit raspy. Okay, so this presentation has three parts. I'm going to start with background information on the topic and broader context for the research. Then I'm going to go on to describe our research project itself, design and methods. As Jan said, I'm a methods expert, so that will be a third of the presentation. And this is a pretty sensitive topic, so it's extra important to put a lot of intentionality into research design. And then third, I'm going to narrow in on project findings, most centrally what participants said and asked for regarding health communication in the healthcare system in Canada. As I'm going to cover a lot of material in 30 minutes, I ask that you please keep questions to the question period. Part one, the topic. So to start with, some definitions and context. What is intersex? Intersex is an umbrella term for innate variations in sex characteristics that do not fall strictly into binary conceptions of male and female bodies. So sex characteristics include things like sexual anatomy, reproductive organs, secondary sex features that develop during puberty, or hormones and chromosomes. Throughout the literature and participant interviews, people often reference the idea that sex could be better thought of as a spectrum rather than a binary, to help normalize the idea that intersex variations are a natural part of human diversity. There are over 40 medical terms for a specific combination of intersex traits. So the column on the right is some of the more common ones, though none of them are that common. The estimated prevalence is about 1 in 58 people. And while some variations bring specific medical needs and complications, many do not. So because of this, many people live their entire lives without knowing they have an intersex variation. Though there are specific time periods where people are more likely to find out that they have one. For example, when they go through puberty, if they're having unexpected bodily changes, or if they're an adult and trying to conceive and they're having difficulties, things like that. Also, because of advances in genetic testing, more people are finding out that they have intersex variations than ever before, whether or not they have obvious exhibitable characteristics. The takeaway, regardless of the exact statistics, which we don't have population level data on this, the Canadian government's actually working on it right now. So I suspect in the next few years, we will have better statistics. They're working to modernize sex characteristics measurements. There's a group called the Canada Health InfoWay Sex and Gender Working Group. But the takeaway is that a consistent minority segment of the population is intersex. In our CGP work and presentations, we use the terms intersex, intersex variations, and variations of sex characteristics because that's what's used in scholarship and by international human rights organizations. But on a one-to-one basis, it's important to ask about and use preferred terminology. So some people relate to intersex as identity category, the way that people will have identities around gender and sexuality, while others do not, and will be like, this is just another thing about my body, just like I have brown hair, I have, you know. So overall, it's important to avoid the term disorders. DSD is used in medical contexts, but in that case, subbing in differences or diversity, just because of its pathological connotations. And the last point I wanted to make on this slide is that sex characteristics are often confused with sex and gender identity. Sex is the overall biological sex a person is legally assigned. So it's an umbrella term. And then sex characteristics are the physical traits related to sex. And then gender is the internal felt sense of having a particular gender identity. The intersex community has faced a distinct history of stigma, secrecy, and pathologization in healthcare, rooted in medical understandings of intersex variations as inherently problematic. In the 20th century, the prevailing approach was to treat intersex status as a medical emergency to be fixed and concealed. So medical management typically entailed a mechanistic sex assignment and normalizing medical interventions in infancy or childhood, usually to try to make a person's body conform to a quote unquote female body because that's medically easier for doctors. Non-disclosure of intersex status to patients and their families was also common, usually on the basis of therapeutic privilege. So therapeutic privilege is a principle that healthcare practitioners should conceal the true reasons for interventions when knowing the truth would cause psychological harm. Where people were informed, healthcare practitioners often urged corrective medical interventions, frequently omitting other options and overemphasizing incidental health risks. These interventions were well-intentioned, usually, though. They took place as a misguided effort to try to prevent perceived individual, parental, and societal distress. However, as many intersex individuals and advocates emphasize, these medical practices actually cause physical and emotional harm. So physically, medically unnecessary surgeries often create health complications such as chronic pain, loss of fertility, and the need for regular and reparative health interventions. An example of that is, for example, having your internal sex organs removed and then having to go in hormone therapy for the rest of your life. Or if you had a medical intervention like bottom surgery as an infant and then having to have a series of reparative surgeries and having chronic pain and complications related to that. Psychologically, secrecy and pathologization impede self-understanding and self-determination. And many intersex people have expressed that they internalize shame, stigma, and sense of isolation. Mental health consequences such as anxiety, depression, and post-traumatic stress disorder are also common. And intersex people who are treated in this manner by healthcare practitioners often avoid medical settings and professionals. And then there's this paradoxical issue where because of the physical and psychological impacts of past care and because of just the lived reality of circulating in society as an intersex person experiencing a lot of like stigma and misunderstanding and prejudice, intersex people actually have a heightened need for social, like psychosocial and medical support. 3 decades of advocacy and critique from intersex organizations, medical allies, academics, and international human rights bodies have made important inroads towards medical reforms, and there's a growing international momentum in the arena of human rights and policy protections for people with intersex variations. So this map is made by Intersections, the Intersections Project, which is based out of the EU. I'm highlighting the international movement because it's important background information and also to emphasize that there are shared goals alongside regionally specific goals and lived realities. So I'm kind of zooming out before I zoom into Canada. So what are those broad goals? First, to recognize sex characteristics as a protected ground, to protect intersex people from discrimination, harassment, and violence. To respect bodily integrity and autonomy, ensure that medically unnecessary cosmetic interventions require free, prior and informed consent. So the goal isn't to end surgeries altogether, it's to let people choose once they're old enough to decide, unless it's medically necessary, but that's only a handful of cases. To secure equitable, transparent, and supportive healthcare, So affirmative qualitative healthcare also includes access to full medical information and appropriate psychosocial support as necessary. And then increase public understanding and awareness of intersex variations as natural part of human diversity. So that would reduce stigma, misinformation, prejudice, etc. So there's progress being made along all four fronts. At the same time, it's pretty early on. So now on to the Canadian context. The Canadian context for people with intersex variations is not well established. Canadian healthcare consists of a basic universal system that's provincially run, but following certain national principles of coverage set out under the Canada Health Act. Given that Canada is geographically the second largest country in the world and that its populated areas are spread out, there are structural inequities of healthcare access and service along lines of geographic location. And then there's also well-established ones of social location, so like socioeconomic status, ability, things like that. However, there hasn't been any systemic data or attention to how having a variation in sex characteristics mediates access to and experiences of healthcare in Canada. There's no explicit legal protection safeguarding bodily integrity and autonomy of intersex people, so the protections have to be read in. And there's less formal organizational support relative to the US in terms of intersex advocacy, even when taking the population size difference into account. So it's a relatively quiet movement here. Egal Canada has done a lot of the work, and then Intersex Canada came about in the last couple of years. And then there are also diagnosis-specific support groups. Part 2, the research. So this project was funded by a SSHRC grant, was based out of the CGP, and had input from advocates, academics, and healthcare providers from all over Canada. My role, as Jan mentioned, is the study coordinator. My background is really the S and LC and qualitative methods. Because this project is on health communication, you'll hear me drawing on both sides of my counseling psychology training, the academic lens, and then the applied training in health communication and sensitive trauma-informed stakeholder engagement. I also want to emphasize the variety of backgrounds that co-authors on this have, as I view that as a strength in this work. And if you end up reading the papers, you'll see how that adds to how we approach the issue. The project included 2 branches: an international comparative legal research advocating for explicit protections for intersex people in Canada, and then qualitative engagement research aimed at improving healthcare provider readiness and communication practices with intersex adults in Canada. The qualitative engagement research is my area of expertise, so that will be the focus for the rest of the presentation. This work culminated in 3 interconnected outputs. So the legal and policy analysis paper identifying gaps in existing protections in Canada, the creation of the introductory guidance document for healthcare providers, which was co-written with Intersex Canada, and the qualitative study documenting communication experiences, priorities, and unmet needs. The history of discrimination and pathologization that I covered in part 1 has shaped the intersex community's relationship with research and fostered caution and mistrust. I'm including Interact's policy and participation research as an illustrative example. So Interact is a youth-led, pretty prominent intersex advocacy organization based in the US. And you see here kind of 2, I don't know if you can see my pointer, but there are 2 things I wanted to bring out from this. One is the importance of community involvement when engaging in research with this population, so respectful community input and consultation. And then the second is the importance that what is being researched align with community interests. So this was top of mind when we were designing this work, and I'm going to go over how we tried to do both. Uh-oh. It looks like it might crash. I really hope it doesn't. Okay, good. So participant voices were the core of this work because it's an interview study. So the core of the work and the recommendations, but then we also had multiple stages of community input involvement. So our steering committee involved a prominent intersex scholar and then healthcare practitioners, And Egal Canada, which I mentioned before, is one of the two organizations in Canada that does advocacy work in this. They provide guidance on study design and implementation at the grant level when Yan and Caleb were writing it. And then interested interviewees in a community advisory group based in British Columbia gave feedback on study findings. And then Intersex Canada, which came about in the last few years, as I said, reviewed and substantially contributed to the guide and are a co-author. Also, two members of the steering committee ended up being co-authors as well. This is a classic qualitative methods flowchart of what we did. It's always a bit surreal to see these processes boiled down to streamlined diagrams because a lot of thought went to each stage, but I'm including it to show the intentionality and also the various points community feedback came into it beyond our team itself. So the community-led guides helping inform the interview guide, again, the interviews and the member checking. On all stages of the project, our emphasis was on trying to ensure this research was as insensitive, respectful, and useful to the intersex community as possible. So, for example, designing questions that were open-ended, trauma-informed, and agency-based, and also trying to set up and conduct the interviews along those lines. So that was community input and feedback. Now on to community priority research areas. So while there's a lot of caution and mistrust, at the same time, the community also values high quality, ethically conducted research as an avenue to help improve the recognized disparities the community faces. Our project was designed to align with these areas. So if you add back in the legal paper, overall, our research project addresses each of these 5 key areas. And that's topically. Also, strong qualitative research will include a conceptual model that undergirds how you conceptualize, gather, and interpret data. We purposely employed a conceptual model as agency-based and in fact draws from intersex scholarship because it helps bake an affirmative framework into the research itself. Agency-based care emphasizes the importance of self-determination, bodily autonomy, and fully informed choice. Cocchetti and all. So Cocchetti is a prominent intersex scholar. Speak to the need to address the sociocultural biases and constructions that currently underpin much medical care for people with intersex variations. So pathologizing bodily sex, like bodily diversity, sex binaries, things like that. And then on the other, so there's the sociocultural biases and constructions that underpin medical care. And then adding, because agency-based frameworks usually are embodied, they often will just focus on people's internal processes. But since for intersex people, embodiment and medical care is such a big part of advocacy, they add in the need to implement effective care that addresses embodied health needs. So those could be the health needs related to their specific intersex variations or health needs induced from past interventions. We integrated the agency-based care model with social ecological models that attend to the dynamic, mutually influential dimensions of health communication. So together, these lenses capture the interlocking dimensions in over which health communication takes place and where our agency-based framework could be realized. So again, we brought in the community priority research areas and then also try to bake it into the conceptual framework overall. I'm going to return to this in a second, but health communication analyses often just start and stop with the healthcare practitioner skills and approaches. But here, I wanted to just illustrate how this worked in practice. So for the research section, I just talked about what we did, how we did it, and why we did it that way. I want to return to design to also just cover what was novel about the project. So a conceptual framework was novel within qualitative research and health communication. It was also significant within the Canadian context to get lived experiences in print and academic venue rather than circulate an impact discourse. So at the time we started working on this, there were only 2 papers on this specific topic. That's such a small group that I'm now email friends with those authors, and actually they got involved in the project itself. Research centering intersex voices, lived experiences, and needs is discursively critical within scholarship on intersex care and practically critical to affirmative advocacy and policy initiatives. The paper was the first to include perspectives both from intersex experiencing health communication on the ground and people trained and working in the Canadian healthcare system on what is needed towards affirmative health communication as a status quo. These groups are not often in dialogue in the literature. There's a kind of a rife relationship there. So interviewing both was an accomplishment on our end and also contributes to a fuller understanding of the issue. And then finally, the guide was the first of its kind in Canada. There are ones for other countries, but it's important to have one for the Canadian context. So it filled an important need there. And it's getting some academic and media attention, which is a good thing because we want people to hear about it and we want healthcare practitioners to use it. Part 3, the findings. Yan, how am I doing for time? I can't.
You got about 3 minutes left.
Oh, shoot, really? Okay.
You know, more or less. You can use one more or two more.
Okay, so I'm not going to be able to spend the time I was hoping to on the findings, so I'm going to quickly, I'm going to pick some key slides. The heart of the project was these qualitative interviews. I just showed there are 3 interlocking axes for change: the skills and approaches, structural access to care, and norms and discourses. And then I'm just going to go ahead to what people wanted. Okay, so what people wanted, they wanted intersex care to be a standard part of medical education. It is not in Canada at this point. So healthcare providers described not receiving, it was quite rare that they received education on this. What they want, like when they were equipped to interface with intersex people, is because of their own individual efforts, or there were a couple of disciplines like pediatric endocrinology and genetic counseling where they were taught. Welcoming healthcare environments, because of what I was talking about with the structural barriers where people don't necessarily know if they can interface with a healthcare practitioner who's equipped to work with them, people ended up often reading environments for cues. So there are ways that healthcare practitioners and organizations can just signal to people that the place is equipped and ready to provide affirmative care. Accessible and relevant health information delivery. So a common theme in interviews also was that people would be meet with a doctor, maybe they have a cold or something, and then their intersex variation becomes the subject of the entire appointment. So to try to move away from that. Person-centered trauma-informed care, having the doctor kind of be familiar with the history of care and how difficult it was and be prepared to interface with that in the ways that people might be nervous, what the people are bringing into the room with them, understanding the psychological impacts of health communication and healthcare. And then person-centered care, compassionate, respectful care, where you get to know the person, you treat them as an individual. There was a quote from one participant that if you met one intersex person, you've met one intersex person. And then people also called for naturalization, normalization of variations in sex characteristics as an aspect of human diversity. And participants, I want to say, did a lot of work themselves towards this. And I think it was also the people we drew from who would volunteer for this type of study, but the healthcare practitioners were doing things like giving talks to various audiences, participating in affirmative research. Intersex participants would go and talk to medical students, things like that. But they wanted to take the overall goal being to recognize intersex variations as a natural part of human diversity, and even taking a step further to actively appreciating what being intersex brings and contributes to the human experience. So our findings really showed that intersex adults in Canada has continued to face systemic gaps and barriers in communication, care pathways, and recognition. And they pointed to clear actionable avenues for change across healthcare training, practice, and policy. And they show that achieving affirmative communication of status quo is not just about individual healthcare practitioners. It will require attention to structural access factors, organizational cultures, and the norms that shape how intersex people are understood. If you look at our project, if you zoom out, also, meaningful progress will require coordinated work on multiple fronts, so including strengthened legal protections, better resourcing of services, and broader societal awareness to create sustainable long-term change. I realized I had to rush to the last part. I'm very happy to share these slides if people want to see more about the findings.
Thank you, Terese. That was excellent. So is there any question for Terese on this presentation on intersex and healthcare in Canada? Maybe I can just get you started with one question, which would be, now that we've developed this communication guide, I mean, there's still much to do to improve the outlook of how intersex individuals are receiving care in Canada and are treated by the Canadian system. I mean, it goes beyond healthcare. So what would be the next steps we should be working on? If there was a follow-up to this project, where would you see it?
Beyond healthcare,
Well, not necessarily beyond healthcare, but beyond that guide. For me, I see the guide as it was like almost a first step. I mean, it took a
yeah,
long time to get there, but it was almost a first step, right? So
absolutely.
where do we go next?
I see one immediate need being so the guide was uh, designed with an audience of healthcare practitioners. There could be a corresponding guide for intersex people about their rights in the Canadian healthcare context and also navigating healthcare systems. And I actually think it would be very useful because people so much like finding doctors was word of mouth or reading reviews or just going into a room and just hoping for the best or having to educate the healthcare practitioner. There's no like national database of affirmative providers. Equivalents exist for other uh, groups. There's like one of trans affirmative advisor healthcare providers, for example. So also like putting resources into like amalgamating all that community knowledge into some national database that people could access as patients.